So it's my pleasure to introduce our presenters, Catherine Westman-Glab, Margaret Miller, and Amanda Radley. Catherine graduated from Brescia University College with a Bachelor of Science degree, Honors Human Ecology in 2003, and proceeded to complete her internship at Grand River Hospital. She has been fortunate to be employed by Grand River Hospital throughout her 19-year career, working predominantly in rehab, including stroke rehab and complex continuing care. Catherine has worked frequently with older adults and has participated in various stages of the stroke care pathway, including teaching primary prevention strategies in an outpatient lipid clinic, as well as contract work in both long-term care and home care settings. Catherine is currently working on quality improvement projects to identify and improve low intake dehydration in older adults, and has been fortunate to work on organizational ITSE projects and the supervision of interns completing needs assessment for secondary stroke prevention education in their region. Margaret is a registered dietitian at Grand River Hospital. She graduated from the Applied Human Nutrition program at the University of Guelph and completed her internship at Grand River Hospital. She has worked in several different areas within Grand River Hospital, including oncology, medicine, stroke, and pediatrics. She's been working as part of the interdisciplinary team on the integrated stroke unit for the past 7 years. She feels privileged to walk with patients and their families and support them along their stroke journey. And new to dietetics, Amanda completed her Master's of Applied Nutrition at the University of Guelph in 2021. She has since worked in acute care, inpatient rehab, and outpatient rehab programs at Grand River Hospital. Amanda has shared her time with hospital-based quality improvement initiatives, including a proposal to align nutrition and stroke care with best practice guidelines and implementing the nutrition care pathway into the inpatient low-intensity rehab program. In her clinical practice, Amanda is a strong advocate for patient-centered care and the role of nutrition in supporting stroke healing. She is passionate about facilitating education for both her patients and dietetic students within the hospital's student practicum training program. And with that, I'll turn it over to Catherine, Margaret, and Amanda.
Hi, everyone. So just to clarify, I'm Margaret, and I'm currently working in the integrated stroke unit on the acute care side of things.
And I'm Kathy, working predominantly in rehab, including stroke rehab.
And I'm Amanda. I cover both inpatient and outpatient stroke rehab.
So as Tina mentioned, today we'll be presenting the building blocks of better nutrition and hydration post-stroke. Thank you for joining us today, and I'd just like to begin by acknowledging that the land from which we present today is situated on the traditional territory of the Neutral, Anishinaabe, and Haudenosaunee peoples. I also acknowledge the enduring presence and deep traditional knowledge, laws, and philosophies of the Indigenous peoples with whom we share this land today. So our learning objectives today, I think you probably have in front of you, but just to highlight those, we're hoping that we can help you understand the prevalence of malnutrition and dehydration and why it's important, identify barriers to intake, identify persons with stroke at risk for malnutrition and dehydration. We'll describe the sequelae of malnutrition, learn the building blocks to support better nutrition and hydration, screen for malnutrition using a validated screening tool, and describe diets, textures, and alternative feeding methods. So we hope that by the end of this presentation today, everyone who's here with us, regardless of discipline, feels a little bit more comfortable in their ability to identify patients that may be at risk for malnutrition and dehydration, and also to maybe gather some tips and tricks to help support our patients along the way. Every member of our team is really integral in improving nutrition and hydration status. We know that we might have some dietitian participants with us today, so most of what we will share might not be new to you, but we look forward to sharing our experiences, and we hope that we may even get a chance to hear about yours. So the problem with malnutrition and dehydration, we thought we'd start with describing exactly what we're talking about first. So we'll be focusing mainly on undernutrition, which Espen defines as a state resulting from a lack of intake or uptake of nutrition that leads to altered body composition, decreased fat-free mass, and body cell mass, with diminished physical and mental function and impaired clinical outcome from disease. So pretty significant. We'll also be speaking about low intake dehydration, which means not drinking enough to replace obligatory fluid losses, characterized by a raised serum osmolality, and it's also distinct from dehydration related to excessive losses, which we won't be touching on as much today. So it's not surprising probably to anyone that 3 dietitians sitting together will be speaking about why malnutrition matters, but we're really hoping by the end of this that we'll show you why it should matter to everyone, not just us. Canadian stats are showing that on admission to hospital, about 45% of med-surg patients in acute care arrive at the hospital already malnourished. So that's almost half of the patients coming in through our doors. When we look at the incidence of dehydration, we also see that about 1 in 3 elderly patients are dehydrated on admission to hospital. So they're already in a danger zone. And then if you can kind of imagine hours or maybe even days of NPO orders, swallowing problems, prolonged hospital stays, functional barriers, all of those things can further impact malnutrition and dehydration. When we focus in on the literature around stroke patients specifically, we can see a really wide range in the incidence of malnutrition, anywhere from 17 to 72%. I think even if we look at that lower 17%, it's still significant enough that it's something that we want to do something about. But why is there such a big range? When we look at stroke patients and that population, it's really not a very homogeneous population. There's a great deal of variability because it can happen to anyone and because it happens in an instant. We could be looking at a wide range of people based on age, and we know that older age is associated with a higher risk for malnutrition. We could be looking at the presence or absence of chronic disease or comorbidities that again can directly impact nutritional status. So someone who comes in previously well-nourished and young are going to be much better nourished than an elderly patient coming in with multiple comorbidities. Different patients may also be on medications or not that can have numerous side effects. It might impact appetite, taste, thirst, polyuria, can have all kinds of different impacts on intake and therefore nutrition status on admission. And then we can look further at muscle mass, people who come in with a higher muscle mass and people who come in with a lower one. We know that stroke activates catabolic pathways, and that can actually be amplified in patients who are more malnourished. So we know that it's a big issue. There's lots of people presenting to hospital who are malnourished, but why should we care? What are the outcomes that we're looking at that can be impacted? So we kind of can separate it out. So we know 50% of our patients in hospital are malnourished already. From a hospital perspective, that can lead to an increased length of stay up to 3 days. It can also add to the cost of hospitalization, on average, about $2,000. From that systemic perspective, that's a really significant impact on patient flow as well as the hospital budget. I think to me, the more impactful statistics are on the human side of things as well. So patients who come into hospital malnourished are 8 times as likely to die and twice as likely to be readmitted. When we look at stats for dehydration, they're actually pretty similar. Patients who come dehydrated are 6 times more likely to die over the ensuing year. They're more likely to be readmitted, and they're more likely to have delays in their discharge. So the good thing is that now they're in the hospital, we're going to be providing 3 meals a day, we're going to be sending Ensure, so for sure they're going to get well-nourished while they're in hospital, right, Nina?
So whether a patient is malnourished at admission or well-nourished, malnutrition can continue to be a risk while they're in hospital. So this can be for a multitude of reasons, but something we want to touch on is the physical barriers to intake. So if you want to take a quick look at this picture here that we took of one of our hospital rooms and try to find any of the barriers that could impact the patient's intake during their stay. So we've got a number in order. The head of the bed is flat. So that makes it hard for the patient to sit up and eat safely, comfortably, let alone just feed themselves. Their glasses, number 2, are far out of reach. It prevents them from being able to see the tray, see the food, eat what they like and enjoy. Number 3 is actually our call bell. It's far away from the patient and hidden from view. This is not only a safety concern, but it can also prevent the patient from calling for help to fix any of these problems. The tray is also pretty far out of reach from the patient. It's putting the food out of reach or not able to actually get it to eat it. And number 5, the tray is not set up for the patient. Leaving the food unopened can physically prevent them from feeding themselves, especially if they don't have the strength or dexterity to open packaging, lids, and things like that. So physical barriers, as we established, can affect a patient's intake. We also have other options as well, or other problems like uncut food. If the patient, needs their food to be cut up in order to eat it, they likely wouldn't be able to eat a piece of meat, an omelet, French toast, any of those foods. If they're missing condiments or sauces that make food more palatable or able to swallow safely, trays being taken away too quickly, so patients aren't able to take their full amount of time to eat everything that they possibly would in that meal. If they're missing their dentures, their glasses, or hearing aids, preventing them from being able to consume things on their tray, or cutlery and dishes that have been adapted post-stroke for any physical deficits, or even just ignoring or not addressing medical needs like being nauseated or in pain or constipated can affect your appetite and your overall intake. We can also look at barriers from an organizational lens. So things like inconvenient meal times. Everybody eats at different times of the day, and patients can find different meal times to be more or less conducive with their appetite. Having incorrect food delivery, the wrong food getting to the wrong patient, can lead to a barrier in intake, as well as food being too hot, too cold, low satisfaction of the foods, as well as too large of portions. A lot of our older population get overwhelmed by too large of portions, and that actually puts them off of eating, as well as missing cultural foods, especially if you don't recognize the foods that you're being given, or you're missing your comfort foods when you're sick. You don't like the flavors, you're missing certain things. That could be a pretty big barrier. Having inaccessible thickened fluids. So for our patients that need thick fluids, not having regular and easy access to those products can prevent them from meeting their hydration needs, as well as the distracting environment or limited staff that can prevent a patient from getting the help that they need, as well as even just fasting for an upcoming test, missing a meal, or nutrition just generally is a low priority for staff or patients.
After learning about all these barriers to feeding our patients in hospital, we can't forget about other challenges commonly faced by our stroke survivors. Muscle weakness, paralysis, and apraxia can all impact a patient's ability to access and consume food. Some patients may also eat or drink less to reduce bathroom trips. You can see from this list that so many daily functions we often take for granted can be affected after a stroke. The ability to move yourself into a safe eating position, access and see the items on your meal tray, and the ability to communicate wishes can all be limited. From a cognitive perspective, your patients may not be alert enough to eat at meal times, forget how to eat, or be unable to focus on their meals. It is important to identify the source of a change in cognition in case there's a reversible cause that can be treated to improve patient outcomes. Hyponatremia, B12 deficiency, and dehydration, for example, could all present with cognitive changes. Post-stroke depression and mental health changes are common, and it's possible your patients may experience low appetite, little interest in food or eating, or be sleeping through their meals. This is certainly a situation where utilizing your multidisciplinary team to support your patient and find areas of interest to promote quality of life could translate into better mood and potentially improved intake. Dysphagia is common after stroke, and the risk of malnutrition and dehydration is high in this population. Some patients recover their swallowing function quickly, while others may have longer-term challenges. Texture-modified foods can be less visually appealing and lower in nutrients and calories due to the higher water content needed to achieve the correct texture. There is often less variety of compliant foods and thickened fluids to help meet needs. Now imagine if your patient has a food allergy or follows another therapeutic diet, how limited their options could be. So picture this, you have a patient that follows a halal diet. While in hospital, their swallowing worsens, and it's recommended that they go on a puree diet. Now, 2 days later, the doctor orders a low potassium diet. After trays are adjusted for these diets with available hospital foods, what is left on the tray? Very little. Without intervention, this patient is unlikely to receive much to eat and variety would be lacking. Patients who would benefit from thickened fluids also face challenges. Thickening agents can alter the taste, hydrating effect, and acceptance of those altered fluids. Negative comments and reactions made about the food can also reduce the chance your patient is even going to try the modified food. So try to be supportive. I'm sure we have heard it all over the years from well-meaning friends, family, and caregivers. Here's your baby food. I wouldn't feed this to my dog. What mystery dish do we have here today? Someone's already chewed your food for you, so that will save you some time. I wonder when someone will get you some real food. You wouldn't want to try your food either if someone described it in this way, and no one could blame you. Identifying the food items and finding something positive to say can go a long way. If this is where we really want to view food as medicine and an important part of the care plan to support functional recovery, think along the terms of advocating for meal intake as part of each patient's therapy. Our best practice guidelines show it is important to individualize care. We should all clearly inform patients and family of the reason for the recommendations and what previously enjoyed or preferred foods may no longer show up on their meal trays, along with the risks if they do not follow the prescribed diet. A patient may be willing to eat a texture-modified diet for a short period of time to try to strengthen their swallow, but long-term they may have different wishes. Open, unbiased communication allows for improved therapeutic relationships. There is a delicate balance between reducing aspiration risk and minimizing or maximizing quality of life. If a patient chooses to eat at risk, consider other ways to reduce complications like pneumonia by encouraging good oral care, which was shared in a previous presentation for this series. Working closely with our SLP colleagues and advocating for regular swallowing reassessment or the consideration of a free water protocol may help this group know that they are being heard and allow them to continue to make informed decisions. The role that malnutrition plays in functional recovery is under-recognized, and being malnourished is much more than just weight loss. Malnutrition impacts every body system. Our cells are constantly rebuilding and our body needs the necessary materials to do so. Loss of muscle function is a major area of concern. In the early days of poor intake, you may notice some muscle weakness without major changes in muscle mass. When dietary intake is insufficient to meet requirements over a prolonged period of time, the body draws on functional reserves in tissues such as muscle, adipose tissue, and bone, leading to changes in body composition. Muscle loss equals reduced strength equals reduced recovery potential. Cardiorespiratory function is also impacted. Reduction in cardiac muscle mass is recognized in malnourished individuals. This results in reduced cardiac output, reducing blood flow and oxygen to vital organs, and making your heart work harder. Micronutrient and electrolyte deficiencies from both poor intake and refeeding can also affect cardiac function. One key point to remember in terms of our stroke patients is that poor respiratory muscle function reduces cough pressure and the ability to cough up secretions, delaying recovery from respiratory tract infections. This is a population with high prevalence of dysphagia and risk of infection. In terms of gastrointestinal function, adequate nutrition is important for preserving GI function to allow us to digest and absorb our food. We also see an increased risk of infection and delayed wound healing in malnourished patients. Lastly, let's not forget all the emerging research on the mind-gut connection. In addition to these physical consequences, malnutrition also results in psychosocial effects such as apathy, depression, anxiety, and self-neglect. The gut produces neurotransmitters, including serotonin, which regulate mood, appetite, and sleep. So we've established that malnutrition is prevalent, it's costly, and to the healthcare system, and it's detrimental to the patient. Now, what are we going to do about it?
So we can summarize the building blocks for better nutrition and hydration through the steps Find, Feed, Follow, which is coming out of Winnipeg. In order to provide the right nutrition care, though, to these patients, we actually need to find them first. So screening our patients for malnutrition and dehydration, as well as knowing when to involve the dietitian, are key to finding those right patients. But our next step is to feed them. So in order to maximize their intake, we have to feed them. This can be as simple as providing mealtime support to our patients, but can also help if we look into some of those barriers as well. Finally, we need to follow these patients closely to make sure that we're actually improving their nutrition and hydration status. We need to monitor things like their intake, their weights, their blood work, to know that what we're doing to help is actually enough. So what do we mean by finding the patient?
So when we look at a 2015 study, they decided to look at how nutrition care was delivered in Canadian hospitals. They looked at a hospital where dietitians saw patients based mainly on referrals, which is previously how things were done at Grand River as well. And what they found was dietitians saw about 23% of patients admitted to hospital, but out of those, 45% were already well nourished. 36% had mild to moderate malnutrition, and 19% had severe malnutrition. So what this means is the resources weren't always directed to where they really needed to be. By seeing those well-nourished patients, we missed 75% of mild to moderate and 60% of severely malnourished patients. So we weren't really finding the right patients. It's really difficult to identify malnutrition. You can't look at someone and say, absolutely, that person's malnourished or not. And there's no singular diagnostic marker that can tell you whether a patient is malnourished or not. So how do we get there? A group of researchers in Canada have actually developed an algorithm pathway to identify, to treat, and to prevent malnutrition in hospitals. It's been titled the INPAC pathway, the Integrated Nutrition Pathway for Acute Care. And it involves first screening patients to detect that risk. And that can be performed by any healthcare professional, but typically is done as part of the admission protocol by the bedside nurse. Assessment can then be done to diagnose malnutrition, and that's performed by a registered dietitian. Each patient then receives standard nutrition care. And what that does is it ensures patients have access to their food, have sufficient food, and food that they're able to eat, as well as access to sufficient hydration to meet needs. So this is that minimum level of care provided to all patients, regardless if they're well-nourished or malnourished. Patients are then monitored to ensure that there's improvement, and advanced care can be implemented. So this would be a process for promoting energy and protein-dense foods. So that could be through prescribed diets, it could be through nourishments or supplements, and all of that to treat malnutrition. Our most at-risk patients and our most severely malnourished patients would receive specialized care provided by a registered dietitian. So there's a number of steps to take, but I think it's important to circle back to that first find the patient idea and look at screening. So there's many different validated nutrition screening tools available, and they've been validated in many different patient populations. Grand River Hospital has chosen to adopt the CNST, or the Canadian Nutrition Screening Tool. As you can see, it's two really simple questions. The first is, have you lost weight over the last 6 months without trying? And the second is, has your intake been less than usual for more than a week? 2 yes answers triggers a referral to a dietitian for further assessment. So it's simple, it's easy, it's cheap, it doesn't require any special training. And at the same time, it's also been validated and tested for reliability in Canadian hospitals. So I think we can see that malnutrition is prevalent enough that it makes sense to screen. And we might argue that it's actually ethical to screen. It might be unethical not to. We can't assess every patient in hospital just from a resource perspective, but we can screen every patient for malnutrition upon admission. The sooner patients are identified, the sooner the appropriate intervention can be implemented and hopefully have a positive impact on outcomes.
There are many reasons why patients may not drink that we should be aware of to find the highest risk patients. Factors such as decreased sensation, not wanting to ask for help, or being worried about incontinence can all play a large role in low fluid consumption. Adults 65 plus have the higher risk of dehydration, and although this should be something we look out for in all of our patients, the elderly are especially at risk. Finding dehydrated patients is difficult, especially with our elderly patients, as biomarkers and physical signs and symptoms may not be reliable. ESPEN guidelines recommend the use of serum osmolality to screen for low intake dehydration, but access to this test is not always available at every institution. As part of some recent quality improvement work to review current practice and barriers to fluid intake, available literature was reviewed to look for short, simple, valid screening tools to consider trialing. The GULP was one screening tool looked at, and the GULP is a dehydration risk screening tool used to assess the risk of dehydration in an individual. And it was created by the Food First team, which is part of the Cambridgeshire Community Services NHS Trust. The G stands for gauging 24-hour urine output. The U stands for urine color. The L stands for look for signs and symptoms, and the P stands for plan. This was a very simple to use screen with plans varying depending on if the patient scored a low, medium, or high risk of dehydration. But when it looked through some of our current charting practices and readily available data, it wasn't quick and easy for us to complete. So without regular access to biochemical screening with serum osmolality or a screening tool, look through the literature, and this checklist I thought was very helpful to identify some risk factors or red flags that you can look for in your patients. So firstly, we're looking at health history. Health history should include pertinent diagnosis and meds. Think of those meds that impact fluid balance and also those that impact lab values typically used to identify dehydrated patients. When we go to physical assessment, we're including things like your vitals and weights. Low blood pressure could be a sign of low fluid intake. Rapid weight loss can also indicate dehydration. And be aware that physical signs like dry mouth that can indicate dehydration can also be related to some meds, and as such, we have to be cautious with some common physical signs interpreting them. Functionally, consider, is your patient able to care for themselves, self-drink or self-feed? And thinking about the presence of depression or cognitive impairment then can impact a patient's intake. Personal hydration habits are also really important. Does the patient stop drinking at 5 p.m. to avoid incontinence? Are they a sipper? Do they drink most of their fluids between meals? If you know your patient's hydration habits, you can make sure you provide fluids to patients when they are most likely to drink them.
So other situations where we might require or benefit from a referral to a dietitian outside of the CNST could be when patients are NPO for a prolonged period of time. There could be wounds or pressure sores, suspected malnutrition or dehydration, poor intake of food or fluids, and a change in status. Because there is some lack of specificity. CNST has been found to have a specificity and sensitivity of 70%. So 30% of patients could be not caught if we use that alone. So if we also highlight other spots where we could refer to a dietitian, that can help improve malnutrition and dehydration as well. So now that we have a plan in place for finding the at-risk patients, let's move on to how we can support feeding our patients.
So once the dietitian has completed their comprehensive assessment, they're going to use that data to determine the most appropriate nutrition intervention. So it's part of the dietitian's role to assess for potential diet changes. So we could provide a therapeutic diet, things like a low sodium restriction, or liberalize a diet, like removing the low fat diet when someone's intake is poor. When we're making these decisions, it's imperative that we're weighing the importance of the therapeutic diet with the risk of malnutrition. Often those more restrictive diets can lead to lower intake, especially if those preferred foods aren't allowed. And we want to make sure that we're not overly restricting to the point of increasing the patient's risk of malnutrition. We also want to consider the need for any additional calories or protein. So especially for our patients who are on a dysphagia diet or any of the restricted diets, they might need a little bit more, and so we might need to add to their trays. And it's also the dietitian's role to determine if nutrition support is appropriate and then discuss with the family and medical team. When we are considering all the above treatment options, we really need to focus on the patient's goals of care. So nutrition care plans can be a total range of intervention from gentle to invasive, and it's within the patient's right to choose how intensive they want their care to be. This is also a very dynamic process. So if things change with the patient's status or goals, we can always adjust the nutrition intervention. So I want to take a quick moment to highlight that our presentation is really focusing on malnutrition and our malnourished patients, but there are actually people out there who are well-nourished, who have a stroke. And so what do we do for patients like that is we want to focus on healthy eating strategies to prevent a secondary stroke. We want to talk about things like whole foods and less processed foods, having a diet that's rich in fruits and vegetables, whole grains, lean proteins and plant-based proteins, high fiber. We want to have lots of water, low sodium, and not having too much fat or sugar.
And good hydration practices are not just for those with the dysphagia or high risk. Everyone needs to be following good hydration practices. So this is part of our standard care. But as we all know, a lot of our patients are struggling with this. It can often be in an area where the whole team may need to help support good hydration practices. Recognizing that we get some of our fluid intake from foods, the European Society of Parenteral and Enteral Nutrition suggests we aim to offer 1.6 liters of fluid a day to women and 2 liters of fluid a day to men with our elderly patients in the absence of medical conditions that could impact needs. There are numerous weight-based calculations we can consider, but we found in the literature to aim for a minimum of 1.5 liters to avoid underestimating fluid needs in frail and underweight patients. It is not likely feasible in most organizations to calculate individual fluid needs. This seems like a reasonable starting target to try to aim for. In order to reach these recommendations, we can make sure that the preferred fluids are available within hospital limitations, offer a variety of beverages frequently during the day, in addition to reminding patients to drink often. We can also save fluids from the meal trays at the patient's bedside for them to drink later. If a patient's preferred fluids are not available and it's not reasonable or feasible to obtain them, developing a close relationship with family and friends to possibly provide and enjoy beverages from home may be beneficial.
So for patients whose meal trays may not meet their calorie and protein needs, we might need to utilize some of our more nutrient-dense foods. Getting to know your hospital's nutrient-dense foods can help you guide your patients when you're encouraging them to eat, especially for our patients with a low appetite or for those who are feeling full quickly. We want to focus on having them eat those most nutrient-dense foods first when having a meal or a snack. And this is the best way to increase the amount of nutrition that they're actually taking in and getting them closest to meeting their needs. We can also increase the availability of foods and fluids through snacks. This can help a patient have just more opportunity to eat and drink to get them closer to meeting their needs. We can also offer things like oral nutrition supplements, things like Boost and Ensure, in order for them to have a concentrated nutrition supplement to get them closer there, especially for patients who find it easier to drink than to eat. You could also utilize a MedPass program, which is a small volume of that concentrated nutrition supplement spread out throughout the day at medication times and distributed by the nurse. And then if we're still finding that oral intake is not enough to meet their needs, we can look into supplemental enteral feeds through feeding tube in addition to their meal trays. So I want to quickly shout out our SLP colleagues who do a great job in using our swallowing assessments to determine where we want the patient to sit for their safest, most appropriate diet. On the screen here, I have the IDSE framework, which is the International Dysphagia Diet Standardization Initiative, which just shows a continuum of diet textures into fluid consistencies for a standardization of care. Our patients with dysphagia may require this modification for their food or drinks in order to be safe when they're eating. And again, like Kathy said, in order to get the food to be the appropriate and safe texture and consistency, extra water may need to be added, which inadvertently can reduce the amount of nutrition available in the food. As such, we want to make sure we're offering a lot of those high protein, high energy foods, and in order to meet their needs. Again, as well, we want you to be very mindful about what you say when you're giving patients their trays, because if you're making negative comments, it can make people feel more hesitant to actually eat what's there. And here I actually have a picture of one of our modified texture trays. This is a pureed tray with mildly thick fluids. And I want you to consider yourself being the patient. You might be confused or delirious post-stroke. You've been determined that you need a pureed diet, you're safer with thick fluids. And then this tray is put in front of you and nothing is opened. You're not quite sure, you haven't been told what a pureed tray looks like, what you're anticipating to get. And so it might be confusing to know what you've actually received, and it may be challenging to navigate the tray, get what you need out of it. So here we have a pureed entree that's fish, carrots, and potatoes. You have a thickened cream soup up on the left-hand side. The lid is still on, so the patient may not be aware. We also have our high protein butterscotch pudding, and then 3 thickened fluids. We have thick water, orange juice, and apple juice. And then we also have an empty mug, and this is for the staff to pour that thickened soup or any of the fluids into the mug so the patient can actually self-feed using that handle. Now, this would be something that needs to be communicated to the staff. So it's not only the patient that could be confused, but it could be staff as well. If you weren't aware that this is a strategy that we were using for helping the patient feed themselves, you may just ignore the empty mug altogether, and that's preventing the patient from being able to feed. Now, we did calculate the calories and protein for this specific tray, coming out at about 650 calories and 29 grams of protein, which isn't too bad for this specific one, but we do always want to be aware that having a moderate amount of protein on our trays and a good amount of calories can help our patients to really thrive. Now, our last stop is the nutrition support. If our oral diet strategies are still not working, if our patient is unsafe for oral intake, or we can't use their GI system whatsoever, we may need to investigate nutrition support. So our first step is always to try to use the GI system when possible, using our enteral nutrition or tube feeds. If we still cannot get to that place, then we could use TPN as well and feed intravenously. Now, again, we always want to consider the patient's goals of care before starting any invasive care plans, and continue that conversation while they're in place in case their goals change.
How can we find patients whose risk levels are changing? What about those whose nutritional status is declining? We do this by following. I think we can all agree that the ultimate goal of our nutrition interventions would result in improving our patients' quality of life and functional outcomes. But how do we measure that? So what can we measure? For those of you who work with us, you may feel we are hyper-focused, even obsessed about our patients' weights and intake. These two measures are two of the limited sources of data that we can access to measure the success of our intervention. Regular accurate weights are arguably one of the most valuable data measurements we can monitor to know if our interventions are working. A patient can be eating 76 to 100% of their trays and still be losing weight. Without completing regular weights, we may not know if the current care plan is adequate. Consistently seeing that a patient is eating less than 50% or avoiding some foods can be very helpful in finding patients that need more help. We have tools that can better track a patient's intake, like calorie counts, ins and outs, and meal round reports. If concerns arise, which we really appreciate being completed to help us adjust our plans. Many electronic charting systems have a place to chart intake. If you have the ability to comment beyond the percentage, that can be really helpful. The Impact Pathway also has the My Meal Intake tool, which can be useful, especially in the meal round report capacity, as this form focuses on both fluids and food items, as well as barriers.
So we're monitoring weights, we're monitoring intake, and We also might want to consider rescreening. The IMPACT actually suggests weekly screening of patients for their risk of malnutrition, because we've seen that patients in hospital, their nutrition status isn't static. It can become worse due to various factors that Amanda and Kathy have chatted about already, and it can improve if we have the appropriate interventions started early and following through. So again, weekly screenings are recommended to improve nutritional status. We could also consider rescreening with a change in patient condition, if a patient's transferred to another unit, if intake is documented as less than 50%, and if diet changes. So particularly in our stroke patients, if diets are downgraded or if thickened fluids are implemented. So a study that was just published in September of this year has come out of Korea, and they actually looked at malnutrition in subacute stroke patients specifically. So they were looking at subacute stroke patients with dysphagia and comparing them to those in the acute phase of stroke. And what they found was it actually worsened. So they found in severe protein energy malnutrition in 12.2% of acute stroke patients, and that increased to 44.8% of patients with subacute strokes. So what this indicates is that subacute patients may actually require more active nutritional assessments. Whereas when we initially think about it, we might think that initial presentation of stroke is more important. So lots of factors can influence that. Longer time on texture modified diets. So we know that's lower nutritional value. Eating 100% of trays may still not be enough. Menu fatigue can flip in. I have patients that can tell me what's coming up on Tuesday supper because they've been in hospital for so long. Aspiration pneumonia, UTIs can increase needs, and longer-term frustrations that can develop around inability to open packages, inability to self-feed. So all of those things can be considered along that stroke progression.
So as part of following our patients, we can also look at ways to improve intake through an organizational lens. Communal dining options really went away with COVID, but we do have research to support that this practice of eating together can improve intake, social connection with patients, and willingness for patients to eat, as well as staff feedback so that it was easier for them to provide more mealtime support when patients are more centralized. Having support during meals, either through dedicated staff or volunteers to open packages, set up meal trays, prompt patients to eat, and even providing meal assistance can improve intake, can decrease length of stay, and provide a positive patient experience. We should also advocate for protected meal times when possible, which is a practice to reduce and prevent mealtime interruptions like staff visits, tests, procedures, therapy. Allowing patients to have their full allotment of time to eat everything obviously will increase their overall intake. Having a full amount of time helps them eat. Improving access to food and fluids between meals also increases the opportunities patients have to eat or drink enough. This is especially helpful for those who only have a small appetite or can only take in a small amount at a time. And then finally, knowing who's responsible for nutrition care. Who's providing water between your meal trays, who's opening packages, who's providing the snacks. This is an early step to take in order to improve nutrition care within our hospital wards.
We hope that we have been able to show you that the role nutrition and hydration play deserves a little more consideration to help support our stroke survivors. In an ideal world, there would be enough dietitians to see every patient, but that is just not feasible. As such, the last building block to build better nutrition and hydration is you. Help us foster change. We need to start thinking about nutrition and hydration as medicine. We want every patient to have the best chance of recovery. Everyone has a role in promoting adequate nutrition and hydration. In this last screen, I'd invite you to look up the reference as it expands on this, but we want to highlight some simple things we can think of first to try to change our culture about nutrition and eating and improve intake to our patients. We ask managers to clarify your processes and address barriers to intake, and to ensure proper staff education on the importance of nutrition and hydration. We ask doctors and nurse practitioners to consider liberalizing diets when that's possible and where appropriate to provide more food options to our patients, and refer to the dietitian when available. Nursing and clinical staff, we ask you to help us with the screening of our patients, to support patients during meal times and address potential barriers to intake, and help us measure and monitor intake and weight. Overall, food is medicine. This is how we should be promoting this. This is just a brief list, but we hope today that you understand how important this matter is and you can help us in our fight against malnutrition and dehydration. Thank you everyone for joining. Please take the time to complete the evaluation for this presentation. We're happy to take questions now.
Thank you. So we do, yeah, so please, we have time for questions, so you can use the Q&A. You can use the chat if you'd like. You can also raise your hand if you'd like to ask the question verbally. That would work as well. So we have one question to start in the chat, in the Q&A, and this is from Karen. Karen is saying, I don't know if you can answer a question about tube feeding. For a non-ICU stroke patient, are you typically making the decision to NG feed if they cannot eat within 3 days, even if they were previously well nourished? Our stroke nurse had wanted that followed since it indicates this in the beststrokepractices.ca.
So I will field this question. Yes, absolutely 3 days is within the best stroke practice guidelines. Now, obviously the guidelines don't reflect every single scenario. So we do want to have that be a dynamic conversation. At the 3-day mark, we want to have a plan in place, or at the very least start the conversation. So some families want to be more aggressive with their nutrition intervention. Some families want to hold off. We find some medical professionals have different approaches to ways that they want to address the swallowing versus the nutrition. So while we do aim for NG feed at that 3 days of NPO mark, it's not necessarily something that we're able to guarantee.
And I think we often rely on our SLP colleagues as well, because they have a good sense of if and maybe how soon that swallow will recover, so that we're able to have oral access again. So that becomes part of the conversation as well. It's only one day though.
Okay, thank you. And then we have a second question from Mariana. Do you reach out to families to address nutritional issues and for education?
So we do reach out to families when it's appropriate. Obviously, with patient-centered care, we want to go to the patient first. But if the patient is delirious or they have any sort of aphasia that we haven't been able to work through with our communication team, with SLPs and the CDAs, we may need to reach out to families, even to find those preferred foods, what can we put on their meal trays that they'll be more interested in. And then we always want to look to see who the best person to receive that education is. Ideally, the patient receives the education, and then if it's somebody else that needs to be involved, like a family member, if it's the person that's doing the grocery shopping and the meal preparation, if it's the person that is going to be the family touch point, they want to obviously be included in the education as well within the family's idea of how they want to function. We always want to be more flexible with how families work and understanding that there's different dynamics.
Okay, thank you. Someone had raised their hands very briefly, so I don't know if anyone else has any questions. You will see in the chat that I have put in the evaluation link, as well as a link to our upcoming Stroke 101 presentation on December 14th. Okay. Okay, well, we'll give people just maybe another minute in case they're thinking. We've got a thank you for your presentation. Very well done. Yes.
Thank you.
Okay. Okay. All right. Well, we do want to thank you very much, Amanda, Catherine, and Margaret. It's a fantastic presentation, and to an audience who's able to join us. So as you do, as I see a few people are leaving, as you do exit the webinar, there will be the evaluation option to fill out there. It's very short, but just really helps us support our speakers and planning future webinars. Tomorrow, you will receive an email with the recording of the webinar, as well as a link to the slides. And if you do have a question that comes up as you're leaving or going through your workday the next couple of days, please reply to me. My email's in the Zoom, and I'll be sure to pass it on to our presenters. And just as a reminder, the next Stroke 101 webinar is December 14th. Jillian McGuire and Brenda Dory will be speaking on post-stroke depression, how to screen and treat it to maximize recovery. And again, that link is in the chat if you'd like to register. Okay, so it doesn't look like we have any more questions. You guys did a fabulous job. Appreciate the time that you took to create and present the presentation of all of this great information. So I think we'll stop there, and we will look forward to our next event. Thank you.
Thank you.
Thank you.